Hello and welcome to our virtual rhinoplasty meetings. My name is Dr Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. For episode 8, we moved over to Izmir in Turkey to listen to Fazil Apaydin speaking to us about reconstructing the midvault after hump removal.
So if there are any questions, Cam, I'll be happy to answer.
Wow, Rob, thank you very much. That's great. So if there are any questions, I've already got a number of questions have come in. Please type your question and I will be moderating to go through those. Okay, so let me pick up. The first question is actually from Yves Saban in France. He said, "Dear Fazil, great talk as always. A question, what are your indications in primary rhinoplasties?"
What is?
What are your indications in primary rhinoplasties?
Well, in primary rhinoplasty, actually, Yves is going to learn more about it next Friday, because we have a panel on that, and I'm going to give an introduction on that next week. But in primary rhinoplasties, what I do now is usually it's better when there is no septal problem. Or when I like the dorsum, I started using dorsum preservation as well. I did about 12 of those. I have to revise 2 of them. So for me, it's a high percent, but I started using dorsum preservation too. But for me, usually, spheral flaps is the number one choice. If there is a septal problem, I use spherografts too.
Excellent. Okay, I've got another question here from Samir. It says, in high septal strip preservation rhinoplasty, the upper lateral cartilages are sutured to the septum. The sutures join the shoulder of the upper lateral cartilage and paraseptal clefts to the septum, but these sutures reduce the angle between the upper lateral cartilages and the septum. How does this affect the internal nasal angle and function?
Well, I told about this to Samir. Depending on how wide angle I want, I can keep 3 layers, which is mucoperichondrium, cartilage, and the mucoperichondrium under. If I keep all those 3 layers, turn it in, suture, I've got a very wide angle. If I want a narrower angle, sometimes it is more than normal. If I want a narrower angle, then I can detach the mucoperichondrium at the top and then suture like that. I do not make a relieving cut at the anterior, at the interval angle. I don't do it. I do it up, not interval angle. So, Samir, keep 3 layers, turn in, suture, that's it.
Perfect. Another question here. Thanks for an excellent talk. When do you feel no need for osteotomies?
When do I?
When do you feel no need for osteotomies?
Well, so easy. I make measurements before surgery. It's very important. And I make palpations. When I feel that the bony part is not too wide, I can make some little sculpturing of the bone with any kind of osteotomy, with piezo or with a bird, even with a rasp, and it can be very satisfactory in some cases. I can tell you, I do osteotomies in 55% of my cases. In 45% of the cases, I don't do osteotomies, which means that I see, because in the private setting in Turkey, I see cute ladies nowadays, which is fine. So they don't need osteotomy over time.
Okay. Question is quite an interesting comment that's actually been flying around offline here, is in terms of how do you judge how wide the dorsum should be preoperatively and then post-operatively? Because there's always this fight of spreaders, is do they affect the passage, the airflow, or do they actually widen the dorsum too much? Do you want to add comments on those 2 issues?
Well, it is a very good question. First of all, first of all, always be a good measurement guy. I always measure during surgery. If you measure the area, the dorsal, the key area, if you measure about 12 millimeters, if you end up after you consult, because 12 again, you're in trouble. You didn't change anything. So measure before you remove the hump. Measure the key area, measure the middle third, measure the subnasal. I make measurements there all the time. And you can use your aesthetic eye to make these measurements too, but try to use calipers or other things. When you make those measurements, 3 places, key area, mid dorsum, supratip area. Then during surgery, after osteotomies, they come together. Put your spirographs, switch respirators, and then measure. If you could narrow that width 1 to 4 millimeters, depending on the situation, then you're good. But if you cannot do it, you're in trouble. Second thing, I told you I'm using spirographs a lot, millimeters lower than the dorsum, and then use spiroflaps. In those cases, honestly, I don't have any problem at all. In order to decide how wide it's going to be, the location of the spirograph is going to change. If you suture more superficial the upper part of the septum, you can widen more. If you suture them lower, you narrow more. So it's a kind of a, how can I say, experience thing. There is no free will. You're going to suffer.
Okay, no, that's great. So what exact dimensions would you suggest in female and in male noses?
Well, honestly, I don't make such a direct measurement. I always try to do it on an individual basis because I showed you cute ladies, 160, 155. Very cute lady, about 40 kilograms, 45 kilograms. It's a different issue. More muscular lady, 80 kilograms, tall, different story. Yeah, so sure. In each individual case, you should make measurements and then you should make calculations. Again, I told you before operating, make measurements. I measure everything with Rhinobase and in Photoshop. I measure the pro picture, I measure the picture, then I know what to do.
Okay. Interesting question, might get an interesting answer. What do you do if you find your dorsum wide at the end of the operation, I presume?
I've got a loaded weapon side by side and kill myself. No, I don't do that, of course. Well, honestly, there was a time that I ended like that because I was thinking that was the only solution because I was using fixed spirographs, I was having it with a white dorsum, and I was telling the patient, this is going to go away. In many of the cases, it was going away after 2 or 3 years, but I don't do it anymore. So I don't end up with a very white dorsum at all. Very for that, I don't end up with a white dorsum. Okay. The problem that you can end up with a white dorsum is the spirographs. And if you put them lower, you don't have it.
Okay, a very interesting comment here from Lissandro Martins. He wants to know, do you agree that the inverted V deformity is a result of excess removal of the upper lateral cartilages?
Agree. If I haven't a good question for Alessandro, I wouldn't be sleeping tonight. So Alessandro, thank you very much for the question, so I can sleep nicely tonight. Alessandro is a very hardworking rhinoplasty student. I like him so much. Thank you for the question. I told you, don't be too ambitious in trying to remove the hump. That's why I do not touch the palatal cartilage at all now. I remove the septal cartilage and I use better flaps the way I show you. I don't have inverted V deformity at all anymore. I used to have them in the past, but not anymore. Of course, sometimes nobody's perfect. You can have some irregularities at the end of surgery that you're not happy with. We use camouflage things like dust, the chips, and so on.
Mm-hmm. Okay, great. Thank you. Okay, Roxana has a question for you. She says, Fazil, how do you prevent a subtle depression that sometimes can be seen years after opening the midvault, even after you have reconstructed it properly with flaps and or spreader grafts?
Good question, Roxana. It may happen, and it happens to me too. In those cases, it happens once or twice a year to me. I now use fillers because I give the option to the patient. I say, I can revise you. It can be a 2 hours operation, or it can be a 2-minute thing. Fillers. I can tell you, they love the fillers very much. So I don't charge for the fillers. They come once a year for the fillers. That's it. But if they want me to correct it, I go back and correct it. Because Roxana is right. Because of scar contracture, it can end up differently. Number one. Number two, some part of the sperograph can go down. That can be displaced. It can be the result of that. By the way, Steven Perlman asked me about my haircut. Because of this corona, I'm cutting my own hair now with those instruments, powered instruments.
You didn't use your knife that you cut ribs with, eh?
Yeah. Not for this one, though.
Okay, Prof, Lissandro is just one more question or comment on this inverted V deformity. He wants to know what your opinion is about a tension suture on the upper laterals to prevent the inverted V.
Tension suture, I don't know what tension suture means, but I showed this suture that I put just at the key area. Turn the flaps in, suture it nicely. One part of inverted V is too much bone removal, not only the upper lateral cartilage, okay? If you remove the bone too much, and if the transition from bone to cartilage is not good, you can end up with an inverted V deformity. Another problem with spreader flap, some people detach the upper lateral cartilage too much. The bone can be visible, so don't do that. So suturing is important. I do camouflage with my perichondrial flaps, but sometimes I put there cartilage dust and cartilage chips too.
Okay. George has a question from Greece. Another great meeting. Bravo, Fazil. Sometimes, if you use only spreader flaps, you can see a slight deformity or concavity at the point of suturing, especially in thin-skinned patients. So his question is, do you use camouflage or replace flaps with grafts?
Well, George, thank you very much for the question. If you're going to use flaps in thin-skinned ladies, first of all, don't detach them with the perichondrium. Keep it intact and turn them in and then suture. If you do so, you're not going to see it. And if you put the sutures and you put them tight, it can be a problem. So don't put them too tight. If you still something there, fillers is the way to go. If it's during surgery, if I see it there, I make small, in thin skin ladies, only cartilage dust I put, not chips too much.
Okay. So now, two very interesting questions from Yves again. He says, Dear Fazil, how far intraoperatively do you follow the profile lines and dorsal aesthetic lines that have been established with a patient's stimulation pre-operatively?
Pre-operatively, again, tell me the question again. How?
So how far intraoperatively do you follow the profile lines and dorsal aesthetic lines that have been established with a patient's simulation pre-operatively?
I try to do it all the time because I'm too much obsessive with measurements and with imaging. I always tell my fellows and everyone, you must do the operation before operation in the office. That is why I make imaging in 3 views: frontal, lateral, and basal. And I make measurements in all those, and I try to follow those guidelines. And I have the pictures with me in the OR, or flow measurements in the OR, so I can easily do that.
Okay, so now a second question from Yves is, if you have revisions, what are the main reasons? Dorsal width or more dorsal lowering?
Well, I never have revisions. That's true. The reason why I have revisions is, honestly, number one is septum. Septal deformities is always number one for me. Number two is the tip problems. I can tell you, regarding the Midvault, I don't have much problems, honestly. Regarding Midvault, I don't have much problems. I don't remember many cases that I've been revising for Midvault problems. No, I don't have it. For slight bony problems, but very slight. Some irregularities, not too much. Mostly stapler problems and the tip problems, nothing else.
That's interesting because we had a discussion on SORSSA a couple of months ago, and it seemed to be that when you're really starting out on this journey of rhinoplasty, you actually don't want to take down too much. And the revision is actually to take down more as a beginner surgeon, really. So, but once you're experienced, you know how much you're going to take down, you're braver. You don't want to just go and cut so much away.
Yeah. Well, honestly, depending on the profile thing, look, in all the surgeries I go into, I have two templates made of plexiglass. And these plexiglass are one-to-one guide for each surgery. So during surgery, first of all, I make a measurement to see if it is fitting or not. And during surgery, I have a template in my hand, how it is going to be. I use it all the time. So if I don't reach my goal during surgery, I go back and do things again. So in terms of profile alignment, I don't have a problem. Or
okay.
Very rarely.
Awesome. Okay, a question here from Alex is, when you close the perichondrium, don't you think that it turns the dorsum higher?
I don't think so. No. Look, if you're going to suture and pull it, yes. But if you remember, you're taking a hump. When you take the hump, in fact, you have a surplus of mucoperichondrium there. Most of mucoperichondrium, because the hump is usually cartilaginous, less of the bone. So in those cases, no. But if you try to be too stubborn and make the pass very tightly, you can have it, but I don't.
Okay, how many days do you splint the nose after osteotomies?
Well, in normal cases, 7 days cast. After 7 days, I put the tape for another 7 days. In traumatic noses, in crooked noses, 10 days, I have the cast. After 10 days, 1 more week with the plaster, with the tape.
Okay. We got 3 more questions. We're going to try and work through these at the moment. So from Emma, it says, excellent presentation. Don't the knots or the 4O PDS show on the dorsum with thin skin patients? As a first question. Secondly, how many times do you need to inject fillers?
Okay. In thin skin patients, if I'm going to use sutures, I try to start from the midline and bury the knots in between. That is one thing. And in thin skin patients, usually the cartilages are weaker, so I use 5O PDS. But I still try to not to keep the knot buried as much as I can. I don't want to carry it on the sides. He's right. It's palpable for some time and it gives you a headache. They go away in 6 months, but those 6 months can be a headache for you. He's right.